extensive symposium on cardiology. I take the pleasure to invite our speaker of the session, Dr. Vijay Mathur, pediatric dentist, AIMS, Delhi. It gives me immense pleasure to invite our moderators, Dr. Aarti Ganesh and Dr. Rambabu. Dr. Aarti Ganesh is professor and head of the Department Conservative Dentistry and Endodontics, Faculty of Dental Science, Sri Ramachandra Institute of Higher Studies and Research. She is a great academician with numerous national and international publications in various peer-reviewed journals. To her credit, she has contributed chapters in several dental material and operative textbooks. She is a PhD guide to various research scholars. Thank you, ma'am. We welcome you. We are happy to have you here. Dr. Rambabu is professor and HOD in Dr. Sudha and Nageshwar Rao Institute of Dental Sciences, Vijayawada. To his credit, he holds PG diploma in clinical research and in medical law and ethics. In medical law and ethics. He has publications in numerous national and international journals. I now request the moderators to take over the session. Thank you.
Very good afternoon. And this is Dr. Rambabu. Am I audible?
Yes.
Hello?
Sir. Yes.
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 It is my privilege to introduce to be a part of this symposium. And let me take the honor of introducing today's speaker, Dr. Vijay Prakash Mathur. And he is the professor and head in Department of Periodontics and in AIMS, the prestigious institute of the Indian Premier Institute, AIMS. And sir has been working in AIMS since last 21 years and has been serving at various capacities at national world health programs. And he has been involved in the formulation of various policies and guidelines for Government of India. It's a really honor. He has been awarded so many awards like Founder President Award of Indian Society for the Dental Research and Dr. J.G. Kannappan Award for maximum citations. He received a prestigious Commonwealth Academician Fellowships and in 2014 in University College London. He has more publications than 108 publications and he has cited as reached 1,200 citations with an H index of 21 and I-10 index of 30. He has presented more than 310 papers at the international conferences. He has been part of about 32 research projects funded by different agencies. He works on policy and advisory for the pediatric world health and patient. And also he has so many fellowships. He's the fellow of International College of Dentists, fellow of Pediatric Academy and Commonwealth Academy Fellowship 2014 from UK. And he's a fellow of the Indian Society of Dental Research and fellow of the Dental Science of Royal College of Physicians and Surgeons in UK. And he has a membership in various foundations like editor of chief for the Journal of South Asian Association of Pediatric Dentistry, and is a counselor for the Global Oral Health Research Networks, and is a member in Council of Continuous Education, American Academy of Pediatric Dentists, and is a member of IADR and Publication Committee, and is a representative to the Journal of Dental Research in 2021 to 22, and is a member of IADR Awards Review Committee, and his credits goes unnumberable, and time is not enough to note all those things. And I request Dr. Vijay to take care of these things. Thank you, sir.
Thank you very much, the session moderator, Dr. Rambabu. And thanks to the organizers for inviting me to the symposia, especially Dr. Mahalakshmi. I've been meeting you, ma'am, several times. I can also see on the screen Dr. Murli. Sir, namaskar, Dr. Murli. Dr. Aarti, hello. I cannot see you on the screen, but my hello to you.
Yes, I'm having a little bit of a glitch. I'll be back in a minute with the video.
Yeah, Dr. Aarti, we met you recently. We met you recently in the ISDT conference also. Thank you very much for everything. Before I start my formal lecture, I would like to update on two things because they are directly related to my work, which we were talking in the previous session. I was hearing our previous moderators talking about that. One was the National Oral Health Policy. National Oral Health Policy 2014, the first draft was made. And after that, the government made a committee. The committee had 4 successive meetings. After that, it was submitted to the Health Ministry. Health Ministry has done already one round of national consultation in both Hindi and English. After that, the corrections have already been made. Then every policy has to go to several other departments like Finance Ministry, DOPT, and the PMO for approval before that is put in the Parliament. So as of now, it has already got the Finance Ministry's approval. The file is still awaited at the PMO or DOPT level, where once it is approved from there, then our minister will have to bring it to the Parliament. So it can be any day, it can be years also if the minister gets the response from those ministries. It can be any day, and if the minister doesn't get response, then it can be years together. So, but we are happy that the dental profession has done their work very, very properly. And we are at the last stage of it from our side, from the technical side. The administrative side may take its own time. Now, regarding the initiatives taken on oral health by the Government of India and various governments is that oral health is now not taken as a separate subject. It is part of the National Health Mission. We used to call it National Rural Health Mission before. Now it is National Health Mission. So under the National Health Mission, you do not have separate budget for oral health. Under National Health Mission, there are several components like service provision. For service provision, in the past 5 years, we could generate almost 4,500 dental healthcare facilities at primary healthcare center and community healthcare center level, directly funded by the central government. So that is one part, infrastructure. So that amount is enormous. We cannot even count that because that goes under the infrastructure heading of NHM, and that goes to the state governments and how they spend, how much they are actually getting on the dental chair and how much they are spending on autoclave. That is because it is clubbed for several other departments. We cannot get the exact data, but we can get the numbers that 4,500 dental healthcare facilities now directly funded by the central government. Apart from that, there are several trainings, then IEC material development, then setting up of national cell and state oral health cells that is going on. Almost all the states have now functional oral health cell in their directorates. So that is also a very big achievement. Although many of the states have not hired or have not taken services of dental professionals for running the oral health cell because they consider that running a program does not require an expert. We are the dental surgeons. We are called as surgeon because our work is related to some skill which is hand skill. According to the government, they require program managers to run such programs, and therefore the dental professionals are not there in all the states at the highest level for national oral health program. But cells are working, they are doing their work properly. With the help of central government, we conduct their periodic review. And this time the periodic review is on 25th to 29th October. Every day, 7 to 8 states will join us for meeting. We take a review, what all they have done, what are their plan for the next year of budget. We have to start the planning for the next year's budget from now onwards. So all these is discussed, pre-planned, and then executed. So things are moving. Probably because these things do not have any paper published in our journal, dentistry journal. So it doesn't come to us. So we do not know much. But yes, with time, it should be coming to all of us. And our colleagues in public health dentistry are actually doing a lot of hard work and supporting the government in a lot of tasks. One of them is the Pitt and Fisher sealant project. And I hope it will come in a big way in coming years. Now, please allow me to share my screen.
Yes, please.
Sir, can you see my screen now?
Yes,
So
sir, we
the
can.
topic,
Yes, sir. Yes, sir.
the topic I've chosen is little offbeat, which people do not talk about. And that is the thing that we, the dental professionals, we think that the government is apathic and government doesn't listen to us, and all the governments are giving low priority to oral health. But when I, being a dental professional also, but sitting with the government also, when I sat with them and when I heard them, their perspectives, then I thought that I will speak this topic. Where did we go wrong in measuring dental caries to impress upon policymakers? Little offbeat topic, but very, very important for all of us to listen and then work upon for the future so that we get our policymakers, our funders and our government to oral health. So I work in this great institute, All India Institute of Medical Sciences. You know it for all good reasons. Even the Prime Minister takes the name of this institute in the UN speech and speech on the Independence Day and Republic Day. So you can imagine how much importance has been given. But when we get the importance, it's not that we just get it like that. We have to work really hard. The faculty here are, we are also part of WHO Quality Center for Rural Health Promotion, and we are also support to the government in implementation of National Oral Health Program. This is my department. Some of the pictures with my patients. Some patients are very cute. Some are fortunate and some are not that fortunate, as we can show in the pictures. And we really need to work hard. You will not even imagine that my residents stay in the hospital from 8 a.m. to 8 p.m. The faculty stay from 8 a.m. till 5 p.m. at least. But at least 2 days in a week, I also have to stay till 7 to 7:30 p.m. So that is the amount of work we have to do, not only the patient care, education of the postgraduates and research, but we have to support the government policy. And one of the mandate for us is to prepare next generation of medical teachers. Now here, it's very important for everyone to know that during the COVID time, when everything in the country was closed, all dental facilities were closed, we are the last hope. We did not close. We still kept our departments open for all sorts of emergencies. And if some of you might have read in the newspaper, it was sometime in WhatsApp also, and the newspapers also, 24th March last year was the lockdown started by our PM. 27th March, BJP councillor, a smaller leader from Bihar, he drove his Maruti van for 20 hours because his daughter, 8-year-old daughter, had dental pain and swelling. He kept roaming in rest of the country. He went to Lucknow also. People did not help. He went to Banaras also. They closed the doors of the medical schools. They closed the doors of the dental schools. Nobody allowed him to enter. And he drove down to Delhi. And when he came here, the first talk was, when I found out that the child is in pain, my first answer was, please bring the child. We'll see first, decide what has to be done. Then we'll let you know that whether are we using some aerator or not. And mind you, my department, we treated that child because we wanted to keep the hope alive for the rest of the country. And hope is the final thing which is for all of us to survive. So it's not just for the sake of name we are working in All India Institute, but it brings a lot of responsibility to us. This is very important point which I want to show to everyone, that despite that much of hard work, we also really do a grand hard work for this research and publication to bring evidence in various areas. And last year, before last 2019, we had only 13 publications. But during the pandemic, though our patient load decreased, but we did not stop working. Our number of articles doubled in 2020. And I think by December, we'll cross 50 articles in 2021. So that is the amount of hard work we do. My own, some few of the points about me, I want to tell you, because the importance, it is related to importance to my lecture today, why I'm speaking to you, which is offbeat, little different than what the dental professionals understand. I have attended the previous lecture from Dr. Prabhu. I also attended yesterday's lecture by Dr. Kritika and by Dr. Puralia yesterday. And there are several things which I found that, no, I need to answer to those things. We have different perception, and the government and the general public have different perception. We need to talk on common perceptions, then only we'll be able to achieve something. So I worked in my beginning. After post-graduation, everybody runs for a clinical job. I did a research job for pilot project on National Rural Health Program. soon after post-graduation, when everybody else of my batch was getting a salary of 25,000 and 30,000 in private colleges. That time I decided to join this program, and I used to get exactly 10,240 rupees as my salary. But I remained dedicated to my work. I worked for 5 years for this program. I given my heart and soul. Apart from being a clinician as pediatric dentist, I also worked for the public health for this country. Till now, I have been participant in WHO guidelines and technical framework formulation in 7 different tasks for the government. I have been part of 4 national projects, and 2 more are coming in pipeline. Very soon it will come to all. Then I've been in advisory and technical committees for Government of India and WHO, not only for oral health, but tobacco control, cancer prevention. The government also has national formulary. I'm part to that. And then the Bureau of Indian Standards also has got certain technical committees on digital health. I do contribute there. So before starting my formal presentation, I want to declare that whatever I have collected today is actually a compilation of information from various government documents, websites, and my own personal experience of working with these people. And there's no conflict of interest for speaking today. Now, yesterday's when we were opening this forum, and the initial remarks were that we dental caries has taken a role of pandemic now. We should be qualifying it as a pandemic. So I'm putting this question to you all, and at the end of my presentation, I think we will also answer this. And then why our government and the policymakers are not giving enough importance to dental caries prevention and oral health in general? So these 2 questions, with that I'm starting. We will go ahead and then we'll discuss on this. So what happens is what uh, we see only the partial view. So this image, you can see that somebody who's seeing this image from the right side, that person will perceive that image as a square-shaped object. The person who's seeing it from the left side, they will perceive it as a rounded object, but the reality is it's a cylinder. So this is what is happening between us and the government or the policymakers, that the reality is something else. We are not able to see their perspective, and they are not able to see our perspective. And all because of this, we should be changing our way. Now, before going further into the depth of my presentations, I'll share 4 stories of my life, which changed my way of thinking. And probably that is going to change the way we work for oral health in India. So in 2000 to 2002, we had a health minister. He himself is a doctor. Dr. C.P. Thakur is a big epidemiologist. He worked on Kala Azar elimination in Bihar, and for that he got several awards, and means up to the highest award of WHO he got. So he was a very knowledgeable man. If you people know that there is a system of asking parliament questions in the parliament, so when the government is being asked a parliament question by some of the MPs, they respond to it in the parliament. And for such questions, answers, they seek help from academic institutions and dental council and Indian Dental Association. From everywhere they take help, and then they frame the answer. So in year 2001, when I was too young, there was a question in the parliament which was worded like this, that how many children are suffering from dental caries in India? And then what are the steps government is taking in this regard? So these were very, very pertinent questions, and this came to aims for answering. And as usual, our head of the department that time, they prepared an answer and sent it to the minister's office for reply. When the reply went there, and when the honorable minister saw that reply, he asked that call the people, those who responded this, to my office. So I was supposed to travel with my head of the department there, but unfortunately on the same day, my head of the department got some serious medical illness and he could not go. And suddenly I was the only one facing the minister. So you can imagine a 27-year-old person facing a government health minister. It's really shaky situation for me. Then he asked me the question, why have you written that about 50% of the children are suffering from dental caries in India? I said, sir, I have these 3-4 evidences. So that time we had only 4 studies on children's caries. One was from Chandigarh, one was from Bhopal, one was from Mangalore, and I think one more was from somewhere else in Karnataka. So those 4 studies I took, and the average of that was coming out to be around 50%. So I showed him. Then he said, what methods did they use to measure this dental caries suffering in children? Then I told him that, so this is the DMFT, and this is the way it is calculated. And this is as per the WHO's oral health survey in 1997, and it has been done appropriately, and we can actually believe on this data. He said, yes, I believe on this data. You are correct. The people, those who have done this scientific study, have done it very well. And they have found out the prevalence of dental caries. But where is it written that it is the children are suffering from dental caries? I was jabbed. I said, sir, prevalence means they are suffering. He said, no, prevalence does not mean that they are suffering. And I was thinking that this person is not trying to give importance to oral health. And that is why he's saying like this. He said that I do not believe that the children, 50% children in this country are suffering from dental caries. You can say that it is a biological condition which your definition of dentist says this is not normal. This is a disease. So for a dental profession, it is a disease. But the people do not perceive it as a disease. If 50% of the children are suffering, then the dental departments in all the institutions would have had a 2-kilometer long line every day morning, because 50% of the children means about 20 crore children in this country are suffering from dental caries. Suffering versus prevalence, there is a lot of difference. So if you have a data on suffering, then give me. And I did not have any data. So this changed my perspective of thinking. What do I answer? We did not have any data on that. So a statement for us, as per the most recent study, has come that about 50% of children below 6 years of age are suffering from early childhood caries, which we use very commonly. And also one of the systematic reviews says that 50% of adults are suffering from dental decay in India. But these are the statements which we use at dental profession. Now see these 2 statements and tell me which statement is correct. About 50% of the children below 6 years of age are suffering from early childhood caries is correct, or the early childhood caries is prevalent in about 50% of children below 6 years of age. So the statement on my right, you would say, you would agree that technically that is the correct statement. So suffering is not equivalent to prevalence. Same is for the adults. So please, as dental professionals, we have to remember prevalence is not equivalent to suffering. How? We will go ahead. So for a policy maker, when we go and when we speak that early childhood caries is prevalent in 55% of the children below 6 years of age. But what they want to hear from us is that if this is the imaginary data, I'm not saying that this is actual data. They want to hear from us that about 6 lakh children miss at least one day of preschool due to decay in their teeth. Or they want to hear that about 6 lakh parents take at least one day leave from their work due to decay in their child's tooth. For the treatment, they take leave. So that is causing a lot of financial problem to the country. Productivity is reducing. Or maybe about 6 lakh rupees are spent every month in a treatment of decay of children's teeth by their parents as out-of-pocket expenditure in so-and-so district or so-and-so state or whatever it is. So they want to hear these kind of statements because they do not want to get into the prevalence. They want to see what is the return on investment or what is the actual use of the money if they want to pump in for prevention of a disease. Similarly, for adults, if we give a statement to the government that about 2 lakh adults claim some or the other form of compensation for dental treatment, for dental caries per month, which amounts to be about 40 crore rupees per month to the government or insurance agencies. So they understand these things. So if we convert the people's movement to the dental clinic or people's expenditure, we count, and if we give that projection the government wants to listen to that. Or we can speak that this many people took leave because of the dental problem, or this many people are falling, they are going below the poverty line because of they are expending this much on health. Then only it becomes an effective document for the government. Then the story 2. We did a project for geriatric oral health in 2011 to 13. During that time, when we wrote the project, that time we had some data available from Delhi, which showed us that there is a 20% of the elderly above 60 years are edentulous. So as a part of the project, so project was on something else, but as a sake of courtesy to all those elderly for whom we recorded the oral health related parameters, for them, we also built in our project that we'll be giving them free dentures. So we had built in the amount for about 180 dentures, and we put in as a budget to ICMR. ICMR approved it. There was no problem. So when we screened 900 elderly in the geriatric health clinic of AIMS, out of 900, we found about 230 were completely edentulous. Up to this extent, the findings were still okay. The previous estimate was population based. This was hospital based estimate. So it overshot. It's okay to find that kind of number of edentulous people. But when after screening them in the geriatric OPD, which is in the next building, from there, when we called those patients to come for a denture to the dental center building, only 70 people reported. And then when we explained them that these are the steps for making the denture, we'll give you free. So you have to come many times. So 15 people opted out for the second time also, because probably they are happy with their life or they do not want to come to the hospital so many times. And many people left in between because they thought that making a denture is a bigger trouble, they can live their life. So our perception was little different than what was people's perception about their own health. So that taught us an example that we, the dental profession, we think that what we think is correct for the people, but that is not. So need defined by the professional is a normative need. What is altered from normal, like for dental caries prevalence, we consider that, but that is a normative need of the people, that everybody should have ideal teeth, no caries, that we think, but people do not think. So if there is a need associated with that, then it is called as felt need by the people. And when the felt need is converted into action and people come to you for treatment, is the expressed need. So these are the different types of need which we need to understand before going to the government. There is a difference between our perspective of thinking and people's perspective of thinking, and the government will go for people, not for the profession, until unless it is something which is very, very unique, like COVID. Then story 3 is related to my meeting with Professor Aubrey Sheehan. He was Professor Emeritus in University College London in 2014 when I met him. We lost him in 2015, but he has been a life changer, game changer for dentistry, and life changer for many, many dentists throughout his lifetime. Some of the statements when I met him was, the first statement he gave me, that dental profession did not think of dental disease measurement for prevention and for policymaker. They only thought of about their own. We classified the dental caries based on the treatment need or the type of cavity we have to make and Black's principles to be used or denture to be given, or whether the attachment loss in periodontitis. We have always thought of the dental disease measurements, or all indices are not meant for the policymakers. Our indices have been meant only for our treatment planning. How many dentists are required, that we calculated. How many hours required, that we calculated, but we did not calculate what people want. That was the problem. Therefore, he used to say that our existing methods have failed to impress governments. And he also used to say that DMFT is meant for the dentists, not for the governments. Then in between, we got this publication in 2019. It is a WHO publication which says that ending childhood dental caries. So it was a very, very enthusiastic document which covers so many things. And when this document was released, this map was there in which you can see that yellow means the prevalence of childhood caries in 5 to 6 year old between 35 to 69%, and red is 70% or above. So when this document was released, I got it, and immediately after that, there was an event where I reached before the time, and the Director General of Health Services for Government of India also reached before time. So I had some exclusive time to talk to him, and I was trying to impress upon him that, sir, our country is suffering, the whole world is suffering due to dental caries in children, and so many children. So we should take some concrete steps. And I showed him this map. This was published in this report. He saw it very carefully. He's a director general, so he had a lot of knowledge, in-depth knowledge. And then he made one statement that if the whole world is yellow or red, there must be a serious error in the measurement method for the disease, or people have accepted this disease as part of life. So this statement actually imprinted into my brain. And this is the thing where we have to think upon, that if whole world is yellow or red, whole world has got this much of high prevalence, are all the governments are ignorant? Are all the countries, all the governments, all the people are ignorant about their oral health? We can blame it on our country as we are developing world. But rest of the world, everybody, every government cannot be the same. So if the prevalence of any disease is more than 35%, and we are trying to say that because of this government's apathy in various countries, people are suffering, there is a serious error. He did not agree that all governments can be so ignorant for a disease. And he told me, please think, rethink, talk to your profession, come out with something else. This cannot be true that this many people have a disease, and which you say is abnormal. All governments are saying not abnormal. Almost 80% of the world means the governments have not taken it that seriously. 80% people in this world, or 80% of the countries in this world, cannot be having the people, those who are ignorant or apathic towards oral health. And that was the turning point. After that, I started that, no, I will talk in all possible forums. I'll talk to my dental colleagues that please start thinking the other way, the other perspective, rather than doing your own work. Yes, if you want to do the surgical part, you want to remain dental surgeon, please be focused to your surgical work. Be there, do that work, and leave the prevention part to program managers, to somebody else. We have only 3, 4, or 5 big key messages which can largely prevent dental caries in most of the population. And to convey those messages and to bring about the behavioral changes in people, you do not need dentists to talk. Other people can also do. That's what is my message to you all. So after this, can we convince our friends in health epidemiology to consider about dental caries as a pandemic? This is again a question after so many of my slides which I presented in the story. Then I went into the definition of a pandemic. And I thought that after Kritika's presentation yesterday, I thought that should we try to put in dental caries in the definition of pandemic. So this is a Wikipedia definition which I took out yesterday only after Dr. Kritika's lecture. And this is WHO definition, by the way. So a pandemic is an epidemic occurring on a scale that crosses international boundaries. So the first condition, we are into it. Usually affecting the people on a worldwide scale. Second condition, also we fulfill it. A disease or condition is not an epidemic merely because it is widespread or kills many people. It must also be infectious. So pandemic definition also covers infectious. Now, if you remember yesterday's Abhishek's lecture, wherein he gave a definition. I think Kritika also spoke the same definition, that it is the dental caries is non-infectious disease. The definition itself got so many things. It is a disease of heart tissues mediated by this and uh, manifested like this. So we had 3-4 conditions, but infectious was not there. And they have also given the example, for instance, cancer responsible for many deaths. It is across the boundaries, but is not considered as pandemic because the disease is not contagious. It is not easily transmittable, and it is not even simply infectious. Therefore, as per this definition, we cannot request our colleagues in epidemiology, health epidemiology, or in health ministry to consider dental caries as epidemic. This is my take on it. Then what we did over the last 100 years, we have got several studies from several countries. We had several indices coming up. DMFT, several versions. There was one very, very sensitive index by the name of Muller's index. I'm sorry, I may have made a mistake in writing the spelling here. Then Nayad's index, then the caries susceptibility, then significant caries index, then ICDAS, then CAS, then PUFA, then recently ICCMS has come, which is a modification of ICDAS. Risk assessment is there. All those indices are giving us what? The indices are giving us number of teeth or surfaces affected with caries or with cavitation, with non-cavitated caries involvement, proportion of teeth, number of teeth with dentin involvement, pulp involvement, root caries. But do you think people perceive or understand all this language? The policymaker, they have nothing to do with it. They are not interested. What we can plan to collect with this information is, normally what we plan to collect the information with this is number of teeth requiring operative and non-operative care by us, number of teeth requiring replacements or follow-ups requirements by us, how many dentists are required to treat this many caries, how much material equipment is required if we plan to provide full treatment to all people. So we think of only the treatment part of the projections. We also consider sometimes time required for it. We also think of financial implications required with such data. So this is our projection. What we do normally, and we think we are correct. But what is not covered in this method and what the government want is how much government should invest in dental caries prevention so that an X number of people will not be taking leave from their offices due to dental pain or problem, will be saving money on dental treatment, whether it is out of their own pocket or it is paid by insurance or the government is providing them free treatment. Then the government also want to know that how much is the out of pocket direct or indirect expenditure by the people on the treatment of dental illnesses. Here I mean indirect expenditure is that a person who's getting treatment has also to travel from home to that place. They may have to put their children to somebody else's place in between. They may also have to hire somebody to take care of their children. They may have to take leave, which is a paid leave. So finally, the expenditure lies for the treatment of that disease. So these are the terms which are being used by our policymakers, and they are important for us to record if we want to really impress upon them. So there could be simple questions with our dental surveys that in the last 12 months, how many days or times you could not do these things due to dental pain or other problems in the mouth. It could be you could not eat properly, sleep properly, talk effectively, avoided going to social gathering or meeting people, a social aspect of it, did have a mental stress, had arguments in home or office due to the dental problem in yourself or your children, or other question can be in the last 12 months, how much amount have you spent on the treatment for the dental pain, discomfort, or any other problem in the mouth, or how many days you did not feel well due to dental pain or problem. So these are the simpler informations which can be collected along with our survey. And Dr. Nagesh was talking about the Rural Health Survey 2002-3. During that survey, I think Dr. Nagesh himself was involved, and I was also involved that time. So we know that these questions were collected, but they were never projected the way they should have been projected to the government. In the final report, in the conclusion lines and the action point, what we wrote was only DMFT, attachment loss, edentullousness, fluorosis. We did not project that important data to the government, and therefore oral health was not seen. So now, how do you find out the disease burden? I've been talking about the prevalence versus the disease burden or suffering of the people. So how do you find out? We can have simpler scales like health-related quality of life. So there's a definition for health-related quality of life. And then there's another definition of oral health-related quality of life. Although the concept started in 1978, but yes, people kept on working on it. And nowadays, we have got several scales which can be used to find out the oral health related quality of life that covers not only the symptoms or suffering of the people, that also cover the functional aspect. Even if somebody has good teeth but not able to chew, no caries but not able to chew, even that is a problem. Psychological factors, social factors, like that, these things can be covered using the quality of life tools. They cover mostly the symptoms, the functional aspect, general well-being, family aspect, emotional aspect, and social aspect. So all these things can give a comprehensive overview. We have to measure the quality of life along with all our surveys or all data collection, because we should measure the actual measure of the impact. One of a very important study our endodontic colleagues have published in 2017, it was in International Endodontic Journal, was on the oral health related quality of life after root canal treatment. And that they have found out that, it's a study from Australia, that they did not alter much. So one of the university where the study was done, and they have found out that despite doing root canal treatments and counts in those patients, those who are covered under the government scheme, their oral health related quality of life did not improve much, because their original problems were not solved. The dentist saw towards only the hard tissue. They treated it very well. They did not see whether the tongue is getting stuck due to filling or improper shape of the crown, or there was a pocket. So there was the holistic view was absent. Therefore, quality of life gives you the actual impact of the disease on person, and also the effect of the treatment, how it has improved. Many times we hear from our undergraduate students or the postgraduate students talking that so-and-so patient of class 2 cavity had come. Now, we think as a technical people, surgical people, that class 2 cavity is an important patient. But actually it is a human being behind that class 2. And that person may have not only class 2, but improper shape of the molar. Maybe there is a periodontal pocket attached to it. But an endodontist is, because endodontist or conservative dentist is expert in doing a very good filling. So they do the filling very well, but the rest of the things, then the patient is referred to periodontist. Periodontist does not have time, and we fail to see a person as a whole. Holistic approach is missing. So what is required for influencing the policymakers is, yes, we need quality of life data. We also need economic implications, and we also are supposed to give our calculations. Although the government also has health economists to support them, but if we do not do a ready-made data of return on investment or cost benefit ratio, they are not going to get influence. This is true for all the professions. Even if it is a steel industry, if somebody wants to set up an industry and take help from the government, they have to show that if the government permits us to put the steel industry to me in this place, this much employment I'll generate, this much revenue I'll generate, this much taxes I'll deposit to the government, and then only government gives permission. Initially, we used to think the health is entirely separate than rest of the sectors, and the government should do it on a humanitarian basis. Our thought were correct for the initial few years when it was only related to pain relief. But nowadays, it's a definition of consumerism. Our government has started considering dentistry as a small scale industry. If you do not know, 2 years back, in 2019, Indian Dental Association did a very big program with Mr. Nitin Gadkari, in which dentistry was taken into the under the ambit of small scale industry. They are not considering us for a healthcare provider. We are healthcare provider, but at the same time, we are small scale industry. We also come under the Consumer Protection Act. Although there's some relaxation for us as doctors, but yes, we are under Consumer Protection Act, and Consumer Protection Act is applicable on whom? Those who provide services. So we are service providers to the government. So for the policy makers like ministers, health ministry, finance ministry, they always talk of return of investment and cost benefit ratio. Our calculation may not be exactly the same as any other industry, steel industry or coal industry or any other, or food industry, but we still need to give them. And this is a very good publication by Rebecca Masters. I recommend all of you to please go through this. This was also an eye opener for me, in which they've explained how the concept of return of investment and cost benefit works in health sector for the governments. And this article has started with this first line: an ounce of prevention is worth a pound of cure. But just by saying this line, we cannot hide behind Benjamin Franklin, a big philosopher. We have to prove it. If we do not prove it, the governments are not ready to listen it. So the benefit divided by the cost. So if I have a projection that if I or if my institute does 5,000 teeth pit and fissure sealant today, we are likely to get 10% less caries in the children, those who got pit and fissure sealant, in the permanent molars. And in the coming 5 to 10 years, this much of benefit is there in terms of cost, in terms of time, and in terms of the financial implication to the government. So if the government invests 100 rupees per tooth today, 100 rupees is not only on material, but on the manpower, equipment, everything. So 100 rupees per tooth, if it is a cost of applying pit and fissure sealant, it is likely to give 5,000 rupees saving to the government in next 10 years. Then the government is going to listen to us. So the benefit divided by the cost is the cost benefit ratio, and return on investment is the proportion of the cost. So every year, what is the return on investment? Over a period of time, what is the return of investment? So we may say that after application of pit and fissure sealant, the group which is getting pit and fissure sealant and the group which is not getting pit and fissure sealant, in 1 year, there may not be major change in the caries incidence or new caries in those molar teeth. But 5 years down the line, yes, there is going to be significant change. So maybe 5 years to 10 years, for those years, we will have the benefit. Even then, it is okay to project, but return on investment has to be projected. If we do not project that, we should not expect much from the government. So for calculating cost benefit ratio or ROI, what all we need these data: quality of life, loss of man days, financial implication, direct and indirect costs. Cost of early detection versus the cost of restoration can also be calculated. Cost of preventive program versus definitive treatment over a period of time can be calculated. And futuristic projections that if we do not treat this disease will become like this. I want to give you an example. When I was in London that time in 2014, that time when publication came into the newspaper that if the government does not allow treatment of obesity by doing the bariatric surgeries by the NHS as free of cost to this many proportion of obese people in the country, by 2019, means 5 years from then, the NHS will have to complete its budget only in the treatment of the complications related to obesity. It may be diabetes, It may be hypertension, it may be cardiac problems, it may be endocrine problems. So when the team in the University College London gave this projection, and when it came into the newspaper, it took only 30 days for their government to hire few hospitals to do bariatric surgery only for those fat people, those who are overweight and obese people. The number of those overweight and obese people was not very large. We know that in comparison to India, that country is so small. So they could plan that between 2015 to 2017, out of those total number of people, this many proportion of people, those will be willing, they will undergo the treatment, and the government will be able to save this much amount of their money by year 2019. So such projections worked. In fact, the UK was the first one to have one more publication, but that was finally did not kick off. That was a futuristic study of dental caries, and they gave a projection for 2030, year 2030, that if the government invests this much money by 2030, the dental caries can remain as an extinct disease, or a very low-lying disease in the UK children. That was projected by an Indian, Dr. Raman Bedi. He was the chief dental officer for 2-3 years there, but somehow he could not impress upon his government. But yes, these kind of things are required. So how should we talk to the policymakers? We should present the facts which they can understand. Then we should also do the opportunistic advocacy, that when they have come to us for treatment, we should speak about dental problems. We should publish papers which have ROI and CBR as their component. We should also present or publish papers on pharmacoeconomics, that how the economics work with pharmaceutical agents for dentistry. And we should also do smaller demonstration projects in smaller areas and show the projection how it has saved the money for this particular district or this particular area in a long run after preventive programs. So what we require is, apart from disease burden, we must collect data on quality of life, loss of man days, financial burden due to disease, direct and indirect costs, realistic but scientific economic projections we should be giving to the government. And one more thing which state of California and US has done is that their group has taken out a series of paper and newspaper articles, and they have begun with that the caries in children has inadequate global attention has been given, but it is completely preventable. But they have blamed it to the government and the people that the caries in children is actually the children are vulnerable. They are not able to take their own decision about their own oral hygiene, their dietary habits. They cannot get things, healthy food for themselves. It is the parents who have to get, and it is the government who has to make those things available. So they published it as it is a matter of inequality within the population, within the families, within the society. It is an inequality. We are doing social injustice for the children. We are letting this disease happen. So when such papers came, the government woke up, and you will be happy to know that the government had put special sugar tax for dental caries prevention there, and also tax on tobacco for oral health. And now out of those taxes collected, a large chunk goes to the oral health prevention in the state of California. So such things are possible only if we project it such way. So for all of you, those who talk about children, please start writing that if we let childhood caries happen in children, it is a matter of inequality and social justice by us. So to sum up, I would say that we have gone wrong in collecting data and presenting facts to the governments and policymakers, but we can still work upon useful indicators. And a suggestion to this group is we can also, one center or a group of people can develop a protocol, and that common protocol can be shared with different centers, and different people can work simultaneously on the same protocol and get several such evidences which proves to the government that this works, the prevention works. So more number of publication, more influence to the government and use opportunities. So to conclude, dental caries does not qualify to be called as pandemic. We can say at maximum that this is a disease of significant public health importance. That's what I want to tell to you people at the end of this symposium. And our policymakers and governments can give sufficient importance to dental caries prevention if we provide them with the relevant data as per the public perspective. Thank you very much for the patient listening. My email is given here, so please feel free to write to me. I remain offbeat and I talk little offbeat only. Aarti ma'am, we could not hear you. Please unmute.
Unmute yourself, please.
Yes. Thank you very much, Dr. Vijay. Okay, sorry. Mahalakshmi, you want to go on?
Yeah. Sir, can you stop sharing the screen? Yeah, you can go on. Go ahead.
Yeah. Thank you very much, Dr. Vijay Mathur. It was a mind-blowing lecture. And actually, I have to give credit to Dr. Mahalakshmi because she allowed me to choose this topic to chair. She had a couple of other things for me. I said, no, I want to chair this topic because I was really intrigued by what exactly was going to go on in this lecture. And there are so many takeaways. There are so many gems of points which are there in this lecture. Like straight away, policymakers don't understand data on suffering. That kind of a question never occurred to us. We were only looking at it with all the measurements that we have. We were only looking at treatment. And also the next gem that you said is just don't think you can do everything. Just leave it to the people who can do it. So we want to do the measurement. We want to do the DMFT. We want to do this. We want to do the questionnaire. We want to do the QL, all of that. But I understand very clearly that we should do what we are good at and leave the others, leave the rest to people who can do it well. Then the other thing that you were talking about is the normative need and the felt need and the express need. Now, these are things which are making so much of sense now that we heard you. And therefore, I think for us to have a quality of life or QL in every questionnaire that we do, whenever we take up dental caries in any form is very, very important. Because earlier, when I was just trying to prepare to see what to talk in this particular session following yours, I was thinking about, we know a lot about the science and the didactics about preventing the disease, but we are still not there yet to prevent it. But now I realize after your talk that we are going on the wrong track. We're not even able to, the policymakers are not able to understand what exactly we're trying to do. So this is really mind-blowing points. And the one question that I had right away was how, just before I go on to the chat questions, how exactly does the private institutions play a role in this? Do we just make the QL and send it to you and you will take care of it?
No,
because
no, it's not like that. I want to tell you that whenever, wherever, means whether you are collecting the data in your own department, please keep collecting the financial implication, the quality of life. Collect data, publish it. Don't send to anyone. Publish it on your name for your area population. Dr. Murli will do in some other population. Dr. Rambabu will do in some other population. Like that, if several such evidences are published, it automatically puts pressure on the government. Or some of us will write a systematic review, or some of us will write to the MP saying that please raise the question in the parliament. So like that, the things work like that only. So pressure building will only happen if we have enough of evidence. And for such a large country, one evidence will not work, ma'am. We'll have to do several.
So it has to be, yes. I agree, and we are completely with you. And I'm sure Mahalakshmi also will lead this particular thing as well. And also the return on investment we're talking about and cost benefit ratio that you're talking about is not new to private institutions, because even when we intend for something, even if it's a DCI requirement, they ask us for the return on invest and cost benefit ratio. Otherwise, they're not even going to get us the equipment, which is absolutely essential for the inspection. So this is something that is even not new to us. So I think for the government, obviously, it's definitely going to be required. So there's one question on the chat before we can go on for further discussion. What are the currently available and in place policies at the national level? Are there any available and in place right now? is what is the question on one of the chat groups.
No, ma'am, national rural health policy is yet not available directly to see for everyone. It came in between for some time for the public opinion on that. As of now, no policy is there, but the National Rural Health Program operational guidelines are already there. They are also in the process of revision, but the old ones are still there. The ministry here, they receive several suggestions from our colleagues across the country, and they keep incorporating. So currently, there's one more version going on, which is likely to be inaugurated by the minister in the month of December.
Yes.
Sir, can I?
Dr. Rambabu, if you can take over.
Murli,
Dr. Rambabu, you would
sir.
ask your question.
Yeah.
So thank you, sir. Thank you, Dr. Vijay, sir, for your extensive presentation, which were majority of the clinicians, though we are academicians, basically, as endocrinologists and conservationists, we feel ourselves as more clinicians than academicians. So we are interested to do the cases and to have follow-up rather than thinking that what is the community level or government level policies and all those things is really new for us. And you have given a good insight, assuming that this is like a industry, small scale industry, rather than a healthcare providers. We feel that we are doctors till now, but now we have to feel not only we're doctors, but we are considered as a small scale industry. Maybe we're considered secondary to the medical professions, but this is always conflict for us at the general dentist practitioners. But now you get the emphasis that how we are supposed to convince the governments in order to get more funds or more insightfulness towards the preventive aspects of dentistry, which none of us, or majority of us, we don't know much about it. And thank you very much for your things, sir. We try to do the what are sessions given by you. We try to follow that. Thank you very much for your presentation, sir.
And Dr. Murli, you want to ask anything?
Yeah, ma'am. Thank you, Mahalakshmi ma'am. Thank you, Aarti ma'am. Nice to see you. And sir, Vijay Mathur, sir, I don't know like what to say. It was the icing on the cake, your lecture. And last but not the least, as Aarti ma'am said, it was mind-blowing. I just could recollect a book written by two eminent medical persons who were director of JIPMERS. They have written a book called What is Not Taught in Medical Schools. One Dr. Sethuraman, one Dr. D.K. Srinivasan. So, I mean, I think, no, yourself, Karbanda sir, Nitesh, and Ajay Logani are very soft persons in a nice place. That is the whole problem, sir. I think you don't fight with the government. If myself or Mahalakshmi would have been there by chance, I think would have fought, sir. You are too soft. Yeah.
This is recorded, okay?
Yeah. And I'm just telling you, no problem. So, no, I'm serious. The way you have projected the data, the way you have projected the facts, I don't think it is very difficult for anybody to understand, sir. So you said they don't treat that as a pandemic. Nothing can be a pandemic, just like if you compare to the recent episode of Corona, where some shortage of staff should be there, or some shortage of bed should be there, some shortage of facility should be there. It's not that way. I think if they're going to give 75% to the medical research, I think it's a hard-bound duty for them to give at least 25% of the time and expertise and the funding, which is most important, sir. Right. So you have excellent people.
Yeah, in that aspect, Dr. Vijay, how do we actually ensure, or how do we go about making the government aware of this, or whether any funding agency for that matter, whenever we try to approach them for any particular thing, it gets sidelined.
That is what, sir. That's what we feel bad and sad also. Like we are not any less, or at least okay, if not the life-saving thing, it's still the what do you call it? Definitely it has a direct bearing and influence on improving the quality of life, sir. So with you people around so close to, I think you have some office in your campus itself, right? If I'm right, some ICMR thing in your campus only. So that is the whole thing. And no questions, sir. Absolutely no questions. It's self-explanatory. It's enlightened us so much. What questions to ask you, sir? Nothing to ask. So it was mind-blowing. And keep your good work. We get motivated and inspired by you always, sir. Definitely for the you softly put across things, but very firmly. Your conviction and your the placing of the facts are so emphatic. We should learn from you, sir. Hats off, hats off.
Thank you, sir. Sir,
Yeah,
actually,
and,
it's not fight with the government. It's always because we sit on the both sides of
The
the
art
table.
of
Sometimes
fighting.
they are dental profession. But I tell you, there cannot be a stronger tool than a very good evidence literature. If you have publication, people cannot refuse. The problem is that we write whatever we think of. We haven't thought from the public's perspective. If we start understanding and if we start writing from their perspective, believe me, everything will get the same importance. And regarding ICMR, yes, ICMR had a problem initially, but now Dr. Kharmda is retired from here and now he has joined there as a scientist. So probably he's trying to work out on certain things to get a separate oral health cell or something. He's trying hard, and let's see. In the government, it takes few years to get an action seen. Dr. Kharmda just joined 1 year back, and then it was pandemic, so we could not see any results till now. But yes, the things are in pipeline. We are aware about, and things will move, sir. We will have something coming up positively.
We'll better than this. First of all, we can send a strong proposal for ICDR, Indian Council for Dental Research. Shall we send it with all institutions signing in? That would be very nice, if at all. Like they have.
So regarding the same, the first proposal started in 1995 when we had the year of oral health 1994. If you remember, WHO declared year for oral health. That year's World Health Day theme was oral health. So soon after that, the proposal was sent to the government. But then successive governments have been saying that because the mechanism for medical research remained the same, their saying is that create a oral health cell within the ICMR. You cannot separate oral health from the general health. And I tell you, many of the even the biggest of the organizations, they say that in case of public health, there cannot be a separate oral health and public health. Public health is one. They see the whole human being as one entity. Now that person's health is also important. Obesity is also important. The hair are also important. The cardiovascular health is also important. Like that. So they say, and there are dental is many common factors with many other diseases. So they are actually trying to integrate in terms of public health. They are trying to integrate that all the public health department should have a dental division within itself rather than dental entirely separate in a dental college and a public health in the medical college. So let's see, the time is changing, sir. We'll see several changes.
Yeah, definitely. Time will only answer the thing.
Dr. Paul is there. Dr. Vinod K. Paul is there in the Niti Ayog now. He himself is a pediatrician.
Oh, very nice.
And he is a very, very promising person, and he's been trying very hard. As per his opinion, even his opinion says that the pediatric dentistry department is not supposed to be there in dental college. It is supposed to be in pediatrics department.
Oh,
if you really want to serve the children.
True, sir. True. Actually, they can have a separate wing or something. It's we can always
within pediatrics department of the pediatric dentist.
Thank you very much, Dr. Mathur, and thank you very much, Dr. Mathur. I think I will, at least from our end, we will promise that we will put the pressure on asking the relevant questions and adding to the great work that you're doing. Thank you very much. And now over to Mahalakshmi for the rest.
Thank you, sir. Thank you.
Thank you, Dr. Mathur. You really opened our eyes. Like it's a totally different aspect what we heard today. And I'm sure we all will think outside our box. We are in a cocoon, so I think we'll have to come out of it and really work hard towards achieving what you are. You have achieved a little of what you have achieved and trying to achieve. And many best wishes to you, so that you being sort of a bridge for us between the government and as others, dentists. I hope and wish that you succeed much more in whatever you're trying to do. Thank you so much.
Thank you.
Kavita, please do the honors.
Thank you.
I think
Thank
that
you.
was a wonderful last session of, good coordination of different thoughts among all of you. Thank you very much, everybody, as really opened up all our minds. So as a token of appreciation, I would honor our speaker with a certificate